This actigraphy chart represents a common clinical profile: severe fatigue alongside a rigid, forced wake time of 6:30 a.m. Despite exhaustion, they consistently avoid sleep until 1:30 a.m. A standard approach assumes these empty hours indicate a biological origin, testing for insomnia or circadian disorders. This specific data pattern characterizes a behavioral phenotype known as revenge bedtime procrastination. Clinically, this is the voluntary, deliberate delay of sleep. The patient experiences high homeostatic sleep pressure and lacks any unavoidable external barriers keeping them awake. These patients are typically fully aware that delaying sleep will impair their performance the following day, yet they proceed regardless of consequences. Because the root cause is behavioral rather than physiological, standard sleep protocols often fail to shift the patient's sleep onset. The intervention targets a biological mechanism when the driver is actually the patient's evening decision-making process. Focusing strictly on biological sleep drive ignores the psychological need that the late-night hours are fulfilling. We differentiate these conditions using a matrix. Column 1's insomnia profile shows a patient in bed failing to sleep. Column 2's procrastination profile shows high sleep drive, but the patient stays out of bed engaging with devices. Column 3 represents a natural circadian phase delay. A patient with a phase delay feels biologically alert during late hours. In contrast, the procrastination patient is physically exhausted, but uses cognitive effort to override their internal drive for rest. In some clinical presentations, a patient may possess both a natural evening preference and the behavioral tendency to delay sleep further. Sustaining this delay over months or years eventually degrades the patient's sleep architecture. Constant behavioral delay creates a form of conditioned arousal. By associating the bed with alert, dopaminergic activities, the patient eventually develops an irregular schedule that mimics the symptoms of chronic insomnia. This behavior typically clusters in the late evening due to a predictable collapse in neurocognitive resources. This graph tracks executive function over 16 hours. After managing stress, the prefrontal cortex has less capacity to halt rewarding behaviors. Where declining executive function drops below the threshold needed to resist immediate digital feedback, the patient reaches a neurocognitive failure point. Modern digital interfaces lack stopping cues, specifically exploiting the state of depleted self-control. Patients with ADHD are statistically more vulnerable to this specific failure. Traits such as time blindness, impulsivity, and hyperfocus lower the threshold required for digital stimulation to override the biological urge to sleep. ADHD also involves significant difficulty with task switching. This makes the transition from a high-stimulation activity to a quiet sleep routine exceptionally difficult, especially when the brain is already exhausted. This inability to go to bed reflects a predictable breakdown of executive systems under specific evening conditions, rather than a character flaw. When the sleep onset is delayed but the wake time remains fixed, the mathematical result is a rapid accumulation of sleep debt. The next day, the patient faces significant cognitive deficits, pervasive brain fog, reduced attention, and a diminished ability to regulate emotions. This restriction triggers systemic fallout. Disruptions in satiety hormones occur alongside an increase in sympathetic nervous system activity. This impairs glucose regulation, feeding a loop of elevated blood pressure and systemic inflammation, which ultimately fragments the sleep the patient receives. These physiological and cognitive impairments make daily tasks feel more difficult and time-consuming. Slower task completion further reduces the patient's available free time during the day, which drains their executive function even faster. This creates a maladaptive cycle. The hours stolen at night guarantee a more restrictive and exhausting experience the following day, intensifying the urge to stay awake again. Rigid sleep hygiene protocols frequently fail to resolve these cases. Demanding more discipline from a patient already suffering from an autonomy deficit invalidates their need for emotional recovery. To someone whose entire day is a series of obligations, a strict bedtime routine feels like a final list of mandatory tasks. This perception increases resistance to going to bed. A successful intervention requires a shift toward autonomy-preserving stimulus control. The clinical goal is to fulfill the patient's need for leisure and recovery without compromising their biological requirement for sleep. Patients should first identify the specific type of freedom they are trying to reclaim and then intentionally schedule that protected personal time earlier in the evening. Introducing structural friction can interrupt the automatic digital loop. Simple barriers, like charging phones outside the bedroom, break the cycle before executive function is fully depleted. The 2-alarm protocol helps externalize executive function. A first alarm at 9:30 p.m. marks the beginning of the wind-down phase. This first signal initiates a low-decision transition routine before total exhaustion sets in. The second lights-out alarm indicates the final target for sleep. Streamlining the bedtime routine, completing hygiene, and setting out clothes earlier preserves the patient's remaining willpower for the single act of turning off their devices. Progress relies on repetition rather than perfection. Clinicians should encourage patients to return to the routine after a late night, rather than viewing the schedule as a fragile, all-or-nothing commitment. By restructuring the evening to reclaim autonomy earlier, the patient can transform sleep initiation from a loss of freedom into a protective act of self-care.